of Exeter University. She will give us a talk about the innovative technologies for precision bone health assessment and fracture risk prediction.
Thank you, and it's a pleasure to come and talk to you about osteoporosis. I've been an osteoporosis researcher for over 25 years, and it's one of the areas where we often forget about our patients. These are my disclosures. So in this session, I'm going to talk about some new technologies that are on the horizon. You've probably got a theme here that I like to investigate new technologies, and some adjustments to some old ones as well to improve the precision of those for identifying the patients who are most at risk of having a fracture. I'm going to talk to you about the BINDEX, or the Bone Index tool from Finland, the EchoLite from Italy, and IBEX, which is being developed as a collaboration between Exeter and the company IBEX. So, as you're aware, 1 in 2 women and 1 in 5 men in the UK will fracture over the age of 50, and these are mostly as a result of osteoporosis. And I know in Egypt you have a significant hip fracture burden as well. We also know that vertebral fractures are highly associated with osteoporosis, and they're underdiagnosed at the moment. So this is a plea to everyone to be looking out for patients with vertebral fractures, because these are associated with both excess mortality and morbidity, and they are predictive of further vertebral fractures and hip fractures. In the UK, about 20% of our patients who sustain a hip fracture die within the first 12 months. These are some quotes from a patient group with those with osteoporosis I had the pleasure to work with, and they stated that osteoporosis is frequently silent until a fracture occurs. It is excruciating, painful, life-changing, and the deformity caused by vertebral fractures never heals. They also said on a daily basis we live in constant fear of sustaining another fracture. So this is a real impact on our patients' lives. So hopefully I'm going to give you some tools to look out for those patients. This is the FRAX tool. You can access it from the website here at the bottom of the slide. And this is free for use. We don't currently have an Egyptian population, but there are other Middle Eastern populations in there which are going to be very similar to yours. This uses clinical risk factors, so we have better precision in identifying who would most need to have a bone density scan, or even just treatment for osteoporosis. In the UK, in our patients over 75, we can treat them based on these risk factors alone. So we know that there's a range of risk factors here for osteoporosis, and you can put all of those into the FRAX tool, as you can see here. We also have a tool called Q-Fracture, which is on the right here, which asks a number of questions. They both have very similar performance for identifying your patients with osteoporosis, and so we tend to use FRAX, the tool on the left, more. There are some adjustments which we can now use in FRAX. For patients with type 2 diabetes, we know they have an increased fracture rate, and so we can use the rheumatoid arthritis box to reflect that. And one of the big failings of FRAX is that it doesn't include falls, and so we now have an adjustment which means that you can add 30% to or increase your major osteoporotic fracture and hip fracture by 30% to target your patients who are falling a lot. So this is just what FRAX looks like when it's populated, and in different countries we have different thresholds for treatment, and on the right here we have guidelines which we can use, and we have a moving threshold depending on the age of the patient. And this is just an example of a populated FRAX with a bone mineral density. And just of note, if you are going to be adding bone density into FRAX, you need to be using the femoral neck bone density. And here above the intervention threshold on the right-hand graph, where we move into the red, is where we would treat our patients. And this means that we can better target treatments so that we have patients treated based on not just their bone density, but their clinical risk factors as well. And we will hopefully pick up more patients who are at risk. But in addition to FRACs, we have a major issue in the UK with a lack of DEXA scanners and huge waiting lists. So there's a number of new disruptive technologies on the market. This is the EchoLight. It's radio frequency echographic multispectroscopy, or REMS. It's new technology which is using the spectra of ultrasound to identify bone density. This just uses a handheld probe like any ultrasound scanner, and it actually allows you to measure the spine and hip. And on the right-hand side here, you can see one of the images of the hip, and we then take measurements from that. It has got some reasonable evidence base behind it from the Italian group who manufactured it, and there is a large European study on it as well. It has reasonable fracture risk prediction with an area under the curve of 0.64 to 0.68, depending on the site. And it also has a strong correlation with DEXA. We've done some work on the EchoLight at Exeter and comparing it to DEXA, and we found moderate to strong correlations with body mass index as well. And here's some of our sort of hot off the press results that were presented in September at a conference. And you can see on the top line the EchoLight scans and the bottom line the Bindex, and they're following a very similar pattern, but there's a slightly higher correlation with body mass index for the EchoLight than DEXA, and we need to explore why that is. Moving on to the Bindex, this is another handheld probe, but this measures the forearm and the tibia, and you can either use 3 sites combined with 2 sites, the tibia or the forearm, or you can use just the tibia, and actually there's a good evidence base to say that you don't lose very much in predictive power by just using the tibia, which makes it much quicker and easier. Patients really like this because they don't have to undress, they can just have a short scan of their leg. We've been looking at the precision errors with this. With any new diagnostic technique where we're taking measurements, precision is incredibly important. And in our study, which was well powered with over 30 patients in it scanned multiple times, we had a precision of 1.73%, which for ultrasound is a very respectable precision error and is broadly in the range that we see on DEXA. This could also be used as a triage approach, and in Finland, where it was developed, they've looked at triaging patients with this device, and about 70 to 73% were directly diagnosed with osteoporosis. So it could be a good cost-saving device for the future as well. The IBEX technology, which my colleague Rob Mertens is working on, is looking at how we could use the basic physics principles and the imaging information that we have to identify patients with osteoporosis opportunistically from having their x-rays. And this study has used x-rays and DEXA at the wrist because we know that a lot of patients have wrist fractures with osteoporosis. There's no change to the experience for the patient of this technology because they would have their wrist fracture done normally, but you would do some post-processing. These are the correlations between the predicted bone mineral density and DEXA, and you can see that they're really high with an R squared of 0.787 to 0.88. And if you look at the ultradistal area, they're just slightly lower. But really good predictive power, and this is a tool which we might be seeing in clinical practice in the near future. This is the area under the curve, which demonstrates that we have area under the curve when you can include age and sex as well, ranging from 0.72 up to 0.86. So very respectable fracture discrimination. And this is looking at it with including FRACs as well, and with this the area under the curves actually increased to over 0.9, so very good results for our patients. So in conclusion, there's a number of new disruptive technologies out there for identifying osteoporosis. These are cheap and easy to use, but they do need further research to make sure we've got a strong evidence base for them. There's some FRAX adjustments which can be used now. And the ultrasound methods are particularly useful because they're portable. Hopefully, with new technologies like the IBEX, getting our risk profile of our population, picking those most at risk, will be a reality in our hospitals without having lengthy DEXA waiting lists in the future. And just a sort of plea, we actually need a lot more research in the Egyptian population around osteoporosis. It's an area where we don't have very much data. Thank you.
Thank you very much, Karen.